Are there barriers to use of radium-223? I think one of you alluded to it. And other radioligands, do you find that there's a challenge in getting patients navigated through that multidisciplinary care?
Yeah, so I think, thanks for bringing out radium-223. I think nowadays, people come to the clinic, and many of them actually ask about lutetium, and it's not surprisingly, and even in localized disease, have experienced patient coming asking for lutetium. So I'm really curious about like what is the best sequencing strategies if we are going to apply the P3 data nowadays. Are we gonna do follow by lutetium, or are we gonna use that before lutetium? I think this is still an unanswered questions, and we still need data to get the treatment sequencing here.
Yeah, I think sequencing is challenging. There are data from the RALU study showing that you can give lutetium after radium, but how about from your perspective?
Yeah, I'll say two things on that comment. So one, on the RALU study, I just want to put a little bit of hesitancy out there. It is safe and efficacious. I mean, I guess safe, efficacious, it's an early phase study, but it is safe to give while you're collecting data on that study, right? What we don't really know is the 3-year safety events when we're using radioligand monotherapy as well as radioligand back on radioligand. So I do think some of the conversation we had earlier about cytopenias and things like that, we just need to keep in mind that we really need to think about long-term safety when it comes to some of the use of these drugs, which is a little bit different than perhaps some of the other drugs we give in prostate cancer. And then the second thing is the access concerns. I mean, most oncology practices now have radiation oncologists that can be authorized users to give these drugs, but smaller clinics don't necessarily have radiation oncology. So it takes sending a patient from your practice to another practice in order to get access to that drug. So I think that is potentially a small barrier here that's going to be real in both the urology community that is providing early prostate cancer therapy, as well as in the medical oncology community that don't have radiation oncologists on site. And then the final piece of that is there are some cost-benefit analysis concerns as we start to move more in towards some of these governmental programs that have some of these drugs under a little bit more scrutiny than other drugs. So I think we'll see how the political landscape unfolds over that. But for now, I think it's more of a, do you have it in your practice or not? And then if you don't, is it exciting enough to refer out to? Because patients aren't necessarily demanding it the way they're demanding lutetium.
Two thoughts just to sort of complement what was just said. First, in terms of the sequencing, we need to remember that all radiopharmaceuticals are not equal. Radium has a much more favorable hematologic profile than lutetium does, and a completely different target, right? It's hydroxyapatite and not the tumor. So it's much gentler on the marrow than lutetium is, and so I wouldn't see that, for example, an alpha PSMA-directed therapy, be it a small molecule or even more relevant for the heme tox potential, an antibody is comparable to sequencing with an alpha that's a bone-seeking radiopharmaceutical followed by lutetium for both of those circumstances. So I think that the data needs to be collected, but sequencing is not class specific. It's drug specific, target specific within a drug, and then the size of the targeting molecule and the payload. It's going to be complicated, and we're going to have to work our way through it. In terms of the practice patterns, it's incredibly rewarding and professionally enriching to develop those relationships with nuclear medicine and work together on these drugs, both in terms of development and taking care of the patients. We have a lot to learn. Every day I learn from those folks. And to not engage in those relationships is truly reprehensible, and not to release the patients because you're not in a position to have those relationships is also truly reprehensible. So A, we all need to learn how to develop those relationships, play with each other in the sandbox, and recognize that patient care is that much more rewarding for everybody if we can do that. And for those who live in communities where those relationships just cannot be made, then you have to release the patient, to somewhere. That's just not ethical not to do that.
But I think we're not releasing them, right? It's still so important that we see them just as
Yep.
we would between
Right.
chemotherapy cycles, right? And provide input as to whether we think it's beneficial, whether we should delay a dose, those types
Sure,
of things.
it just depends on what role you take. Like if I'm going to send a patient to radiation oncology for their primary therapy, I think of them as the captain of the ship. I'm there as an oarsman. And with enough comfort level between the two disciplines, I can certainly relinquish the captaincy of that ship to nuclear medicine, provided that nuclear medicine has the skills and takes ownership of a lot of those issues for the advanced patient. And that's up to you to do that education, right? If you want that collaboration, you have to invest in the relationship. And I, like my patients, while they're on lutetium, I do see myself now as an oarsman, as opposed to necessarily the captain, or we co-captain.
Yeah, that's an interesting perspective. So it's so complicated, right, the sequencing, and to throw another layer of complication in, there are combination trials now with radiopharmaceuticals. I think UCSD has taken the lead on one. Any combinations that you predict might be most interesting, whether it's with immune checkpoint inhibitors or PARP inhibitors or something else?
Yeah, I saw a poster presentation at ASMO that combining the radioligand therapy actinium as a one dose. I think this study was led by the Cornell group. Use one priming dose of actinium, and the rationale behind that is try to increase the neoantigen, and then followed by that using the pembrolizumab immune checkpoint inhibitors in traditionally we think the prostate cancer doesn't really work, but I think in that data we see PSA response in their presentation, which is very novel idea and mechanism and rationale to me.
Yeah, and we had seen Prince using lutetium followed by immune checkpoint inhibitor as well. So there's definitely interest, and I think these, unfortunately, the phase 2 kind of trial designs just can't really answer the question, right? Unless maybe we saw some tremendous signal. How about you, Ben? Any?
Yeah, I'm cautious about trying to go down the anti-PD-1 path with any combination partner in prostate, given all of the failures in drug development. But it's possible, right? And that's why you got to do these studies and look for signals. I think in combination, when I think about how do we intensify patients to give a long runway where they're feeling good, it's in the hormone-sensitive setting, and that's the concept behind either SBRT to oligometastatic disease or docetaxel and high-volume disease to debulk the primary, right? So if you have less cells that can become resistant to hormonal therapy, then in theory, you can hypothesize that that patient's going to have a longer runway in that hormone-sensitive phase, which is kind of what we've seen. So how do we bring radioligands up where, one, we may have less overall marrow issues in the future, right? Because there's less disease that's bringing radiation into the marrow. So it might be more effective there. We have a great study out of the Australian group combining, right, giving 2 cycles and docetaxel looks very promising. Now, whether or not that's the right amount of drug, or whether or not you need docetaxel, whether or not you can just get away with an ARPI, I think that's interesting, right? So I personally think using it early when there's enough disease that it can be active, but not too much disease, to keep patients off of chemo perhaps, and in the hormone-sensitive phase for longer. I think that's probably where I'm most excited.
So more excited to move it early versus a novel combination. Interesting.
I think the most impressive combination data that I've seen is Louise Emmett's combination of enzalutamide and Pluvicto, because first of all, there's such a compelling rationale for metastatic CRPC with downregulated AR signaling and upregulated PSMA, and she has actually shown that with the serial PET scans that she did. Second, the data themselves look really good. And third, she did an adaptive dosing schedule, which I think is really a future treatment paradigm. So that study encompasses a lot of things that I like to see in combination studies, which is a biologically sound hypothesis, data that actually supports that hypothesis, and innovative dosing around the combination that perhaps wasn't done in monotherapy studies that are registration trials and sort of a keep it simple precept. For early disease, and I think we have to recognize now with both SPLASH and with PSMA4, I have some concerns that we have now moved we have now 2 phase 3 trials, which we've moved earlier than VISION, which have not yielded a survival advantage. In large part, there are a number of reasons that may account for that. One is our own designs. They had crossovers. 2, they are beta emitters, and perhaps then we should look to alphas as we move earlier. 3, the eligibility criteria perhaps are not enriching as much as we should be for success to get an OS advantage. We'll see what PSMA addition has to yield, but it also has a crossover, similar eligibility, and also is using lutetium. So I might venture to say that before we go really early, we need to get some things sorted out to get the stage set for seeing an overall survival advantage. And that may mean no crossovers, better enrichment, and moving to alphas to really expect early therapy to yield a survival advantage, because I would like to see that actually happen. So there's some prep work and thinking work that I think needs to be done in order to further leverage what is really active therapy to yield a survival advantage in earlier disease populations.
Yeah, there's so much we don't know.
There's a lot there.
Right? And dosing is an issue we just keep coming back to with these radiopharmaceuticals.